everyone. Welcome to this kind of online supplemental lecture for our diversity and inclusion class. Yesterday's class session was incredible in terms of conversation and discussion, and as a result, we only ended up getting through the disability section of our PowerPoint. So, I wanted to put together just a quick lecture to wrap up what we know about mental health and mental illness, because these topics are really important as well for your understanding of diversity within the workplace, and also is going to be relevant, of course, for our case analysis for tomorrow. So I'm going to try to keep this short and sweet, and it might be helpful because I'm just on my own here and there's no one to discuss with. So I'll try and keep it pithy for you all. And of course, if you have questions about these concepts, please reach out to me. If you refer back to the exam study guide, you'll be able to tell which ones from this PowerPoint are going to be on the exam and that you do have to have some familiarity with. I also want to point out that you were assigned to read an article, the Fulmer and Howard Harvard Business Review article. So you should have read that for yesterday's class, which talks about suicide in the workplace. Some of these concepts that are on the PowerPoint also were reviewed in that article. And as a result, you should be familiar with them as well. So just make sure you've read the article as part of your studying. Also, if you hear some beeping in the background, the mail person is at my house, and I'm wildly surprised that my dog is not barking like a mangy mutt. So hopefully no babies are crying and no animals are barking in this PowerPoint presentation. So let's get started. The first thing we need to do is to differentiate between mental health and mental illness. We talk about these terms interchangeably at times, but they are distinct concepts. So when we talk about mental health, what we really are focusing on is mental wellness and the extent to which somebody is mentally well. How much well-being do they have? And what we mean by that is that somebody who's in a state of mental wellness, high mental wellness, would experience a feeling of wholeness, of completeness, a feeling of happiness and potential. You might also consider somebody that has good mental wellness to be in a state of flourishing, right? They're living their best lives, they are feeling their best. Somebody who's demonstrating good mental wellness or good mental health would have signs of clear thinking. They're able to be productive in their multiple roles in their lives. They would exude self-confidence, would be able to maintain stable relationships, might show some signs of optimism and a sense of just overall contentment. So while you don't need to have all of those, generally speaking, these kind of states of mind, these types of behaviors and attitudes demonstrate somebody who has good mental health. On the other hand, when we talk about mental illness, what we're really talking about are conditions, diagnosable conditions that affect how a person thinks, feels, or behaves. And the key here is that you have to meet the criteria for diagnosis. So for instance, for somebody to be considered depressed or clinically depressed, often they have to meet certain criteria that might include certain feelings or behaviors for a 2-week period or more. So if you're having a couple of days that are very difficult or a week that seems to be very difficult, you might not have great mental health or mental wellness, but it's likely you're not meeting the qualifications or the requirements to actually have a diagnosable mental illness. So mental illness is something that's diagnosed. There are clear criteria in order to meet that diagnosis, where mental health really applies to everybody and demonstrates whether or not somebody is flourishing. So we can actually put mental health and mental illness on a continuum, right? 2 different continuum that intersect. So as you can see from the PowerPoint, if you look at somebody who has a severe mental illness, it is possible to have a severe mental illness like an anxiety disorder, like depression or bipolar, but still have good mental health, particularly if that person is able to manage their mental illness and they feel as if they're in a good place managing that mental illness. Then they are still absolutely able to flourish and to feel optimistic and to be productive and all those things that we talked about with mental health is still possible even if you have a mental illness. And sometimes I think the assumption is that if you have a severe mental illness, you can't possibly have good mental health, but that's not the case. On the other hand, it's very possible that you do not have a diagnosable mental illness. that you do not have anxiety, you do not have obsessive compulsive disorder, you do not have depression, but you still have poor mental health. So it's likely that you don't meet the criteria for any of those diagnoses, but you're still not flourishing for one reason or another. So you're not maybe feeling optimistic, or maybe you're experiencing periods where you're not really thinking clearly, etc. So the point of this really is just to highlight that mental health and mental illness are different, and you can have good or high or low mental health, and you could have a serious mental illness or not. And so these things occur at varying levels. So as we talk about mental illness, I think it's helpful just to give you some statistics to let you know how prevalent some of these disorders are, and it kind of helps provide insight into how these topics influence employees in the workplace. The statistics themselves are not going to be on the midterm exam, but I think it's helpful just to kind of set the stage for what we're talking about. So when we mention mental illness, these are diagnosable disorders that are mentioned in the DSM-5, which is the diagnostic manual for all mental illnesses. So this is really the go-to guidebook or handbook that's used for psychiatrists and psychologists to understand mental illnesses and the criteria associated with each of those. So there are more than 200 diagnosable disorders in the DSM, and that's a lot, right? And we might not be familiar with all of them, and some of them have different variations associated with them. For instance, sometimes you'll hear people talking about bipolar 1 or bipolar 2, so there are different kind of gradations within certain diagnoses. In terms of prevalence, from best estimates, we suspect that 1 in 5 U.S. adults experience mental illness each year. So that's about 20%. And when we're talking about U.S. adults, that means we're talking about individuals who are likely of working age and probably have to work to support themselves. Furthermore, when we look at individuals who identify as LGBT plus, we know that almost 50% of those individuals are reporting mental illness per year. So what that means is that the LGBTQ population is experiencing mental illness at a rate that's almost double what the general population is. And that could be associated with so many of the factors we've already discussed in this class related to stigma and stereotypes and discrimination, and how that's compounded when you also have another identity associated with a group that's been historically excluded or marginalized. Some of the most common mental illnesses that we hear are depression, anxiety, post-traumatic stress disorder, and bipolar disorder. So these are the diagnoses that are most common or most prevalent. Of course, they make up the greatest percentage of mental illness diagnoses each year. This obviously does not represent all of them, but you are probably or have heard these terms before. And if you have questions about what any of these disorders are or what they include, let me know. I'd be happy to talk to you about it. So I wanted to set the stage a little bit about just some of the environmental restrictions and some of the kind of societal factors that play into having a mental illness, because we can't just look at having a mental illness as its own kind of isolated thing. It impacts individuals in varying ways in various parts of their lives. So just wanted to kind of set the stage and give you more background information about mental illness and some of the experiences of those individuals who have been diagnosed. So again, best estimates, we know from research that about 46% of adults with a mental illness receive treatment. And so what that means is there's actually about 50% of adults who have a mental illness that are not currently receiving treatment. And there could be a lot of explanations for that. One explanation here is that there's an average delay between symptom onset, so when you first start to experience symptoms of a mental illness, and then when an individual actually gets treatment. So that average delay is 11 years. So there are a lot of individuals who have experienced depression, anxiety, who might be maybe having obsessive compulsive disorder or an eating disorder, and they're really experiencing these conditions on their own for a significant amount of time before they decide to seek treatment. Some of the individuals who experience mental illness, about 11% of individuals who are diagnosed with mental illness don't have any insurance coverage at all. So, not having access to doctors, not having access or the financial means to go seek help is certainly a barrier. And this is important when you're in HR, right? Because it helps kind of highlight the necessity for offering benefits and offering insurance to our employees. It's really in our best interest to care for the whole employee, and one way we can do that is by offering health insurance. We also know that in the United States, 155 million people live in what we would call a designated mental health professional shortage area. So these are areas that have just a lack of certified professionals who are able to give mental health care and treatment to individuals. Now, we are seeing some expansion, through e-health and telehealth, etc., and that's helpful. But for some people, online and e-forms of treatment really aren't sustainable if they don't have access to Wi-Fi, or maybe they don't necessarily trust the providers, right? So it still remains to be an issue. So it's hard to just replace real face-to-face interactions with a professional and kind of replace all those with an internet-based source of care. So there are a lot of reasons why individuals might not seek treatment. Additionally, there's still a stigma associated with mental illness, so people might not want to have a record of being diagnosed. Maybe themselves haven't really come to terms with having a mental illness, and they engage in some self stigmatization that prevents them from getting treatment. So, and in some instances, individuals take medication, and by taking medication, they realize that it also has some trade-offs because there can be side effects of that medication, and maybe they don't like how that feels, and as a result, discontinue treatment and instead opt to have no treatment because they don't like the side effects of medication. So there are a lot of reasons why someone might not seek care, but recognizing 50% of people, by our best estimate, who have a mental illness are not receiving treatment, which is a big number. We also know that white individuals are significantly more likely to seek treatment than individuals of color or racial ethnic minorities. And part of this is that there are great differences in cultural stigmas surrounding mental illness. So many cultures, particularly Asian cultures and Latino cultures, there's great stigmas against mental illness and perceptions of being weak or perceptions of needing to seek care for these types of disorders. And so individuals are much less likely to talk about it, much less likely to come forward for those disorders. And then, of course, there's differences in access to treatment. So if we consider socioeconomic status, as I mentioned before, having access to healthcare, if you live in a very rural area, if you live in a low-income area, there might be fewer mental health professionals. And so all of this kind of intersects with race, intersects with socioeconomic status, and can reduce who is able to actually access care. We also know that there are ripple effects of mental illness. So it's not just having a mental illness in and of itself that might impact your life, but it can reach out into other areas. So at an individual level, we know that individuals with mental illness are less likely to complete high school, which can have an impact, right, on career aspirations and being able to obtain certain employment status, obtain certain amount of income, right? So they're disadvantaged sort of at the start. These individuals are also more likely to be unemployed compared to individuals who do not have a mental illness. And some of this could be challenges associated with managing the mental illness. Some of it could be mistreatment that they might experience in the workplace as they try to manage their mental illness. But nonetheless, again, they're disadvantaged if they are less likely to be employed. We also know that there's a high rate of comorbidity. So comorbidity means that somebody experiences two or more disorders at the same time. And so an individual with mental illness is much more likely to also experience a substance abuse disorder. And there's a lot of reasons for this as well. And sometimes we use substances to cope with our mental illnesses. For instance, that's just one reason. But as you can see here, having a mental illness has these kind of far-reaching implications for other areas and other ways someone could be disadvantaged. We also know that an individual with a mental illness is much more likely to engage in suicidal behaviors or to have suicidal thoughts. And so we see an increased number of suicide attempts and deaths among individuals with a mental illness. At a community level, there are also impacts kind of more broadly on society or, socially when we think about mental illness. And I just wanted to share these facts. These aren't necessarily on the midterm, but I think it's helpful in really understanding this population. So what we know, again, by best estimates, is that 20% of people experiencing homelessness have a serious mental illness. So it might account for why they are unable to maintain employment, and having lack of income can account for not having a place to stay, etc. So we also, again, estimate that about 37% of incarcerated adults experience a serious mental illness, which again has some broad reaching implications for how we treat people through the justice system and who commits a crime and why crimes might be committed, and also what are the effects of somebody being incarcerated. So if you're incarcerated and you're placed in, say, solitary confinement, certainly that's going to have an effect on your mental well-being and on the onset of mental illness. And so again, it's really hard to untangle these effects, but it's helpful to understand. And in recent years, there's been an increased attention paid to veterans and individuals who are in the military and the effect that those experiences can have on mental illness. So right now, estimates suggest that about 15% of veterans report mental illness each year, and that has some serious implications related to suicide as well. So oftentimes I think we talk about mental health or we talk about stress, and we do so kind of at a broad level, but I don't think many classes actually talk about suicide. And we need to talk about suicide because it's important. It's important because it's accounting for a significant number of deaths in the United States each year. And it's really an outcome that is not reversible. If somebody dies by suicide, we have lost any opportunity to intervene. We've lost any opportunity to try to lessen the negative experiences they're having. And at that point, we have a life lost. And I think that is really a serious consequence that has a lot of impact on organizations and on the people surrounding them. So we need to talk about suicide, and we need to be aware of it so that we can help perhaps prevent it. So overall, when we look at the number of deaths in the United States, it's about 50,000 per year of deaths attributed to suicide, which makes this the 12th leading cause of death. But if we look at a younger age group, so the age group in which many of you are, between 15 and 24, suicide is actually the third leading cause of death. So that's a pretty significant number and can help us really understand, what are the life events that are occurring as somebody transitions through, adolescence and into adulthood and transitions from college into the workplace. I mean, that's a really pivotal time point. Of those who do die by suicide, almost 80% of them are male. So we certainly see increased suicidal behavior among men, and that can have implications for our interventions and the ways in which we try to prevent suicide. Related to some of the other populations that we've talked about this semester, transgender individuals are actually 9 times more likely to attempt suicide compared to the general population. This is a staggering number. When I read it, I almost did a double take. It's astounding. And this really goes to, the other efforts that we're making in the workplace to be inclusive can have a trickle-down effect, so that by being inclusive to the LGBTQ community, we can actually improve their mental health and perhaps minimize suicidal behavior and suicidal thoughts. And suicidal thoughts are very prevalent. Again, by best estimates, about 12 million U.S. adults are experiencing suicidal thoughts or reporting them each year. Because suicidal thoughts typically precede suicidal behavior, if we can recognize those individuals who are experiencing suicidal thoughts, it gives us an opportunity to intervene and to help them seek care before they might progress to attempting suicide or even dying by suicide. So I really want to draw your attention to this idea, the interpersonal theory of suicide. This is quite important for your understanding of why somebody might decide to engage in suicidal behavior. So what this tells us, if we're looking here at this green circle, it says there are really two conditions that lead to somebody's desire for suicide. So the first is this thing we call perceived burdensomeness. So when somebody believes that they're a burden to others, that other people would be better off without them, that they're, causing other people distress, or they're just a problem for other people, that's one factor that leads to this overall desire for suicide. The second factor that leads to an overall desire for suicide is this idea of thwarted belongingness, which is when people feel excluded. So the idea is that we all have social needs. We all have a desire to belong and to have social connections. And when we feel like we're not able to form those social connections, that leads to a feeling of thwarted belongingness. So it's really these two states together of feeling as though we're a burden on others and feeling as though we're not making social connections, or we don't have other people in our life we can depend upon when we feel like those belonging needs are not being met. Together they kind of relate to or result in this desire for suicide. The second component that we have to consider is what we call the acquired capacity for suicide. So if we're kind of looking at this yellow portion here. So acquired capacity for suicide really occurs when somebody's fear of death is diminished over time, when somebody, is no longer necessarily affected by pain or physical pain. They're not afraid of physical pain. This can explain to a great extent why we see high rates of suicide among military personnel, among police officers, right? Individuals that are routinely kind of subjected to these high risk situations where they're constantly interacting with death scenarios, and they over time maybe become numb to this fear of death. Also related to this acquired capacity for suicide is really having the means in which to enact suicide. So individuals that have access to firearms, for instance, are going to have much more acquired capacity for suicide. A lot of times when we talk about gun regulations, we don't talk about the impact on suicide, but when somebody has greater access to means to enact suicide, they're much more likely to actually follow through. So it's possible that you might have a desire for suicide. Maybe you're experiencing these feelings related to burdening others, and you're feeling like your social needs are not being met. But if you still have a fear of death, or you don't actually have a means of enacting suicide or following through on it, then you might experience suicidal thoughts, but not actually engage in the behavior. So what we see here, this like green space here, is that when you have these two states of feeling like you're a burden to someone else and your social needs aren't being met, and you have an acquired capacity for suicide, you're not afraid to follow through, you have the means in which to enact suicide, that's when somebody's at high risk for suicide completion or a suicide attempt. And this can really help us hone in on who might need to have an intervention and who we might need to help. So in the workplace, we could certainly give survey measures, and I've done this in my own research quite a bit, to tap these things to assess how employees are feeling. And when they come back that they're feeling high states of these, it gives us an opportunity for intervention, particularly if we're working in organizations like, policing or military or other, corrections officers, individuals who have access to firearms and means on a routine basis. By really paying attention and honing in on those workplace factors as well, we can help minimize suicide attempts. So I think it would be really helpful for you all to go back to that Fulmer and Howard article, because it talks about the ways in which the workplace contributes to suicidal thoughts or behaviors. And so there are many ways that individuals might feel as though their workplace experiences are hurting their own mental health, and ways in which they're contributing to increased suicidal thoughts. So for instance, if someone's experiencing bullying, if they feel isolated, if they're experiencing ostracism where other people are not including them and they feel like they're always left out, those are factors that contribute to suicidal thoughts and behaviors. Job insecurity, abusive supervision, all of these different factors that make that reduces someone's social needs and increases, their feelings of being a burden on others, all of those can contribute to suicidal thoughts. So we have to recognize that there are things that are occurring in the workplace that directly affect whether or not somebody might experience suicidal thoughts or behaviors. So if we can identify what those factors are and we can identify who's experiencing them, it can allow us to intervene in a more thoughtful way. So the last slide here is on the spectrum of suicide. Again, this is covered in the supplemental article, so I really encourage you to go back and read that article. But to know that there are 3 different stages when it comes to suicide prevention. So the first is prevention. This is when we try to look at normal circumstances and problems that someone might experience, try to identify what those are. So that we can better understand which circumstances and problems are leading to suicidal behaviors. So perhaps in the workplace, if we know that job insecurity is a factor that leads to suicidal behaviors, maybe we can be more clear in our messaging, particularly during difficult financial times, to help alleviate concerns about job insecurity. Intervention is when we've identified somebody who has thoughts of suicide or someone who might be at particularly high risk for suicide, and we reach out to them. We try to support them. We try to intervene with treatment or therapy or other community services to get them the help they need to minimize the chance or the risk of them actually acting on those suicidal thoughts. So this is really a critical stage because we've identified someone who's at risk, and it's our opportunity now to get them the help they need, to get them the support they need in order to save a life. And the last stage is postvention. So postvention occurs after a suicide attempt has been made or after a suicide death has been completed. And this really is a critical stage in organizations that is sometimes ignored. So I'm working on a research study right now that's interviewing employees who've experienced a loss of a coworker, or supervisor, or close work companion who has died by suicide, and what the ripple effect of that is, what the consequences are, and how organizations respond. So some organizations might not respond at all, and others might take more collective strategic action to really check in and offer support to those who are survivors, right? Those who have survived after the colleague has died by suicide. So postvention are the strategies and the support systems that we use after the fact, either to help a person who's been injured through a suicide attempt, or how to help those individuals who are loss survivors following someone else's suicide death. So this cycle, again, is really important to understand because this postvention is something that's clearly needed in order to follow up with our existing employees, and also to strategize about what could continue to be done, what further efforts could be made. So again, go back and read that Harvard Business Review article. It gives you more in-depth discussion of each of those 3 stages. So this wraps up the discussion on mental health and mental illness, but if you have any further questions, let me know either in class tomorrow or send me an email. We can certainly meet anytime this week. I want you to feel comfortable and prepared as we go into the exam. So thanks so much, guys. I hope you have a great day and looking forward to seeing you tomorrow. Bye.